To explain to you about the police-involved shooting that occurred on Thursday, February 22nd, in a 500 block of North Nelson. We'll be sharing some videos related to this incident. These videos are quite graphic in nature, so if you are uncomfortable, feel free to turn away from your screens at this time. The videos you are about to see show the initial arrival of responding officers, Mr. Jennings quickly approaching the officers with a large knife raised in his right hand and repeatedly yelling the phrases, "Shoot me, I want to die." Despite the officer's plea for the suspect to back up, he continued walking towards them. They yelled for him to drop the knife. You also see the deployment of the department-issued taser as well as the deployment of a department-issued firearm. Please play video number 1.
He's got a knife in his hand.
Drop the knife, Randy. Drop the knife. Back up. Back up.
Shots fired. Need a medic. Yeah. Shit. Still attached. Hey, we need some bandages or something. Tommy, you got first aid shit in here? Get some bandages just to put pressure on it.
Send him in now.
Yeah, send the medics in.
Okay.
Yeah, I'll get you some. Here. Hey, stay with me, buddy.
Any officers report? Officers report. Yeah.
Where's the man? There.
Shit.
Here, give me some pressure.
Hey, get that chief up here.
Somebody put pressure on it. Pressure.
We also have the body worn camera from the second officer to arrive on scene. We will play that now.
I got a knife in his hand.
Yeah, I got lethal force. Drop the knife, man. Drop the knife. Keep the taser out. Taser him. Taser him. Taser him. Back up. Back up. Back up. Secure the knife.
Shots fired.
Shots fired. Hit 3.
As law enforcement officials, our utmost priority is always the safety and well-being of the community that we serve. Last Thursday's police-involved shooting stemming from a mental disturbance call underscores the complex challenges our officers face when dealing with our community members with mental health crisis. Our officers responded to a situation where Mr. Jennings, armed with a knife, posed a significant threat to himself, other residents, and officers. Despite our officers' best efforts to de-escalate this situation, tragically, lethal force was used. Our thoughts are with everyone, including our officers, affected by this incident, and we extend our deepest sympathies to Mr. Jennings' family. We understand the community's concerns and are fully committed to a thorough, impartial, independent, and transparent investigation into this incident. It is our collective responsibility to continuously strive for better outcomes in these high-stake and emotionally charged encounters. We recognize the importance of open communication with the community that we serve. As more information becomes available, we will keep the public informed to the fullest extent possible while respecting the integrity of the ongoing independent investigation conducted by BCI. We appreciate your understanding during this challenging time, and we remain committed to building trust and fostering positive relationships within our community. Now I would like to introduce Administrator Kuntz of Public Safety Communications. Thank you.
Again, I'm Ken Kuntz. I'm the Division Administrator for Support Services and Public Safety, which also includes the 911 Communications Center. The city is committed to serving the emergency needs of all of our residents, including those in mental health crisis. In recent years, we have invested in alternative crisis response programs to better tailor our response to these calls. This has included the creation of the Right Response Unit, embedding social workers in our 911 center to help handle calls with a mental health nexus. When our 911 call takers receive a call with a potential mental health concern, they assess the call and attempt to determine if they can engage the clinicians in the Right Response Unit. In some cases, the clinicians can defer a police response or aid in de-escalating the caller. In the last 2 years, the Right Response Unit has handled nearly 7,000 calls for service. They were able to resolve nearly 2,000 of those calls without involving police. There are situations where that is not possible, and a police response is required. Those calls involve weapons or violence. The 911 call came in from a man reporting that his boyfriend was attempting to harm himself with a knife. The call taker immediately began gathering the essential details of the call, such as the location, description, and what was happening in that moment. The caller reported that this is not the first time that his boyfriend has done this, and the last time officers arrived, he had a knife in his possession. Within 45 seconds into the call, the caller stated, "He is fighting with me, trying to take the phone away from me." The caller later reports the boyfriend is trying to attack him, refusing to let him exit, and that the boyfriend was trying to punch the caller in the throat. At this point, the safety of the caller also became a concern. Our priority in managing mental health-related calls is to connect persons in crisis to mental health services and clinicians when possible. Given the fast-moving developments and the deteriorating situation where the caller himself was put at risk, the focus became information gathering for the officers that were urgently responding. We continually improve our alternative response program, and some of the adjustments to the Right Response Unit include callers to our non-emergency line, 614-645-4545, have the option to press 3 to reach the Right Response Unit. Currently, that call is answered by a call taker and then connected to a trained clinician. We are working to allow faster access to clinicians by routing option 3 calls directly to the clinician and only go to the call taker if the clinicians are unavailable. We are also drafting more specific policy guidance for the call takers and interacting with the RRU staff and obtaining multiple callback numbers for clinicians to assess. We are planning additional training by our partners at Columbus Public Health for our 911 call takers and dispatchers. It was noted that the housing unit in this police run is hosted and supported by Adam H., specifically for the housing and care of residents with mental health needs. That data was not in our computer-aided system. Moving forward, we will be adding that note to our CAD system to flag the address as potentially in need of engagement by alternative response professionals. This information will be helpful to our call takers, dispatchers, and ultimately police officers responding to the scene. These premise notes are available to be added for any organization that believes their location meets the same criteria by contacting the 911 manager. Our 911 center processes nearly 1.4 million transactions annually. I can tell you firsthand, these are dedicated, caring professionals who take pride in serving our residents during what are often some of the darkest moments in their life. The 911 staff is committed to this community and to providing emergency services. I am incredibly proud of the difficult work that they do every day. And I'll turn it back over to First Assistant Chief Potts.
Thank you. We'll open it up for any questions you may have.
Look at a situation like this, the taser was deployed. How effective did that appear to be? It looked like they were almost simultaneously deployed. Can you talk us through what the training is on that in a situation like this with a taser and a firearm both in play?
Thank you for that question. Sergeant Brooks, can you come up and explain the training that we received? Thank you.
Sure. The taser training runs concurrent with the defensive tactics unit training. We've had tasers deployed since roughly 2005. What we've noticed in almost the last 20 years that every time we deploy the taser, it's only effective in about 50% of the time. You have to think of a taser as an electronic device. It's just like your cell phone. Things can go wrong. And in this case, the suspect's thick Carhartt type jacket didn't let the probes make contact with the skin. If the probes don't make contact with the skin, or at least through a quarter to half inch of clothing, the taser isn't going to be effective. On top of that, the suspect was on the move toward the officers, which is taking away their time to react with the taser. Any other questions about the training?
I have a question. Is there a general rule of when somebody has a weapon, at what point? Is it like a number of feet maybe that an officer can use deadly force?
There's actually, we use what's called a 5-prong test to be able to deploy the taser when there's, in this case, a deadly weapon, i.e. the edged weapon in this incident. The tasers have to, or the officers that trying to deploy the taser have to have some kind of cover. In this case, they were trying to use the parked car, but the suspect's actions advancing toward them, they couldn't use the car for cover any longer, or some type of barrier, something for the individual to have to traverse to get over, like a table, couch, something to that effect. Then there's a distance. A taser is only effective up to 25 feet. And then it's at its widest points. There's a good chance we'll even miss with the taser. On top of that, they have to have the time to be able to deploy the taser, to get it switched in between modes from a close quarter kind of deployment to a distance deployment. And on top of that, they have to have lethal force backup, in this case, which they had. And when you put all those things together, a lot of times in that aggressive scenario, there's just not enough time to make it right, to make it perfect. The usual general deployment distance, we try to get them in anywhere from 12 to 20 feet with the taser, but as long as those factors, time, distance, barrier, and lethal force backup.
Is there a specific distance for, I heard them communicate, have both, lethal and taser in there, but is there a specific distance where lethal force is authorized, I guess, or a general rule?
Well, lethal force can be used at any distance. It, again, depends on the subject actions. If he started taking off from a sprint from the covered atrium there of the front door, lethal force is, effective then, and the officer was still by himself. You really don't want to get someone too close with a knife with you because they can close that distance so fast. The average human being at a walk can close 4 feet in a half a second. So if they're 30 feet away, they're covering that in a second and a half. And it's add to the sprint, and it could get closed quite quickly.
So when it comes down to mental health professionals and that protocol, can you talk to me a little bit about how that would go if you were to make a phone call to a mental health professional to talk to someone in a situation like this?
I'll let the director of communications get that one.
Can you repeat your question for me, please?
Yeah. So in a situation like this, instead of using a taser or some type of lethal force, what would be the protocol for calling a mental health professional?
Yeah, each of these situations are extremely unique when they come in. The call taker is really trying to process as much information as they can. There's a lot of factors that would determine the routing of this call, right, for whether or not the right response clinicians could get involved. And that's really, I think, what we do on a continual basis is when we get these various calls that come in, we try to review them, Q&A them, and see what could we have done better, right? And so in this particular case, one of the barriers was that within 45 seconds, there was threats of violence already occurring. So that right there started to diminish the ability to keep all the parties together in that concern, right? The other barrier is who's calling. So is the person in crisis calling? Is it a friend, a family member, a bystander? Who is calling in? So that kind of factors in as well. And I don't know if that answers your question in depth.
Yeah, that's it. Thank you.
And so just to be clear, for this incident, the RRU was not used in this call?
That is correct. In this occasion, I believe that as we start to Q&A this and really look for opportunities for us to improve our own services, right? From listening to the initial phone call, you could see within 45 seconds, which is very, very quick for a call taker. At that point, she hadn't really even obtained all the information, including the description. The situation was evolving. The two parties were moving. It started to become combative with each other. So that makes it very difficult to obtain all the information that you need when you know that there's a police response that is required, like in this situation. And then at the same time, you know, how do we inject a clinician into this specific scenario so that everybody is safe in this environment while they try to de-escalate, right? So that is always the unique barriers that we are trying to assess on each one of these mental health related calls.
You mentioned that this unit or this apartment complex was not flagged in the system as having a lot of mental health residents or residents with mental health needs. Are you proactively looking at other locations that may have similar criteria to ensure that they are in fact flagged, or is that something that you're relying on them to reach out to you?
Yes, at this point, and it's a great question, thank you. At this point, we are relying on those facilities to reach out to us because it's really individual, right? Some of these agencies do not want to be identified or labeled in that fashion, and where others might want to be labeled that way. That's why it was really important for us to say, listen, if you have an interest in labeling your facility or your address, we have the ability to scale this all the way down to an individual person's residence. If you have a family member that you live with that has these type of mental health related concerns that you feel like law enforcement should know when a call comes into our 911 center, we have the ability to add that as well. But again, we want to take that and be respectful and take that from their queue and not our own.
Can you tell us if there have been previous 911 calls related to this individual involving mental health crisis?
I would have to research a little bit deeper, but and I can't go into too great of detail. However, there was a previous incident involving weapons with this individual.
All right. Thank you, everybody.